This week on the BackTable podcast.
When I open up a dotatate PET and I look at the MIP, and you just know when you look at that MIP image, if it lights up, you say, all right, well, this is getting PRRT at some point, and whether or not it has to be right now or later on down the line. It really comes into that multidisciplinary approach, and we meet every week we have a NET tumor board, and so we're very busy, and we have our nuke med docs and our IR and surgery and GI, and it's nice to be able to get the input of everybody. And other people may say, no, I can ablate that lesion. We're doing histotripsy now, and maybe that patient is not interested in having a needle put in them. And there's a lot of different things we can do before we even get to PRRT. And then we haven't talked about trials yet, but there's a lot of different things that are on the horizon.
Welcome to this episode 3 of Neuroendocrine Tumor Board on BackTable. Today we'll discuss systemic and radioligand therapies for neuroendocrine tumor. My name is Lingling. I'm a GI medical oncologist at Ochsner in New Orleans, Louisiana. I'm also the medical director of the Ochsner Neuroendocrine Tumor Program. Today I'm honored to have Dr. Ramirez and Dr. Liao joining me today for our lively discussion. Dr. Ramirez is an associate professor of medicine and a medical oncologist at Vanderbilt in Nashville, Tennessee. He has a special interest in neuroendocrine tumor and leads the Neuroendocrine Tumor Program at Vanderbilt. He's a member of the North American Neuroendocrine Tumor Society, NANETS, and was previously on the board of directors. He's currently on the nominating committee and scientific review committee. He is a frequent speaker at NANETS and has authored or co-authored nearly 200 manuscripts and abstracts, with the majority are related to neuroendocrine tumor and lung cancer. And our other guest, Dr. Liao, is an associate professor of medicine at the University of Chicago. He's a medical oncologist who specializes in hepatobiliary cancers and neuroendocrine tumors. He serves as the medical director of UChicago Medicine's Hematology Oncology Clinic, the interim director of Gastrointestinal Oncology Program, and the co-director of the Neuroendocrine Tumor Program. Welcome, Rob and Andy. Thank you so much for joining me today.
Thanks for having us.
Thank you.
So when it comes to seeing and treating patients with neuroendocrine tumor, I do feel that as a GI medical oncologist, if we see other cancer like colon cancer, cholangiocarcinoma, pancreatic cancer, the first thing that we're going to do when we see a patient is do an NGS, right? We do NGS, both blood and tissue, for the majority of other GI malignancies. In your practice, in the patients who come to see you with newly diagnosed metastatic, well-differentiated grade 1, grade 2, grade 3 neuroendocrine tumor, what is your approach on the NGS testing? Do you usually do it? If so, do you usually do tissue, ctDNA, blood, or both?
We usually do tissue, and we do it. So oftentimes it wouldn't change our initial management, but we do it sometimes more for academic reasons to help better understand. But every now and then we do find actionable alterations.
What are the alterations that you find that has been helpful?
We found high tumor mutation burden. We found mismatch repair deficiency. Sometimes after the tumor has been exposed to a lot of different treatments. And sometimes we see some fusions that are targetable.
Interesting. How about you, Rob?
Yeah, pretty uncommon to pick up anything actionable. Every now and again, we will find something. We do it. It's not as crucial to do upfront as in some of the other malignancies. So I don't see other GI malignancies, but I see thoracic malignancies, and certainly it's crucial for that population. But it really doesn't change the upfront management for what we do.
Right, exactly. I feel the same way. I would say, I don't know if you feel the same way. I even have a lot of, especially when it comes to well-differentiated low-grade neuroendocrine tumor, like grade 1 KSI7 less than 3%. Even when they have widely metastatic disease, when I check a ctDNA, a lot of times it's negative. So then is it because we cannot find out circulating tumor DNA when they have widely metastatic disease? I don't know if that's been your experience as well.
Yeah, I haven't used ctDNA that often in neuroendocrine.
You'll likely find an MEN1 in there, but it's pretty much the extent of, what you'll see. I think it's more crucial to work, make sure you have your imaging done, your multidisciplinary team, your pathology review, have all of that in place. rather than waiting on molecular testing.
Exactly. That's definitely a completely different approach compared to, like, say, thoracic oncology or like pancreatic adenocarcinoma. And I also feel that maybe because of the location, a lot of times I would say if it's more aggressive tumor, say higher grade 2 or grade 3 neuroendocrine tumor, I kind of feel that there's a higher chance that I can pick up something, say VHL or CHEK2 or sometimes like ATM and BRCA. And a lot of times we can also pick up germline BRCA mutation or ATM mutation. And of course, that will help us, like when we consider chemo in the future, what will be a better chemo or PARP inhibitor, things like that. But definitely not like changing our management when we first start seeing a patient. Then it comes down to management. A newly diagnosed metastatic, well-differentiated grade 1 or grade 2 neuroendocrine tumor, how do you decide between active surveillance versus starting them on a somatostatin analog?
Yeah, that's a good question because there's definitely a group of patients who would be appropriate for surveillance without treatment. Generally, we think about, how the patient is, their comorbidities, their age, and what their natural prognosis would be, right? Because if the neuroendocrine tumor is the least of their problems, starting treatment can actually lead to side effects and, time burden, financial burden, and things like that.
Yeah, I agree. I think not everybody needs treatment started right away. One of the big things I look at is to see if the patient has had prior imaging. And so many times we can find something. I see a lot of lung nets. And so sometimes these patients come in with lung nodules and we get a biopsy and it shows a low-grade neuroendocrine tumor. They're completely asymptomatic. And they tell me, oh, yes, I had a scan done 5 years ago for a kidney stone. And so we'll track down that scan and sometimes we'll see that nodule that was there. Those are the patients that we can watch comfortably and say, all right, well, we know you have this cancer, but it's not doing anything and it's something we can watch and maybe you won't ever need anything for this. But similarly, if patients, again, have low burden of disease or asymptomatic, especially the grade 1 tumors, maybe they've had their primary tumor taken out already and they have a few residual nodal metastases that are picked up on a dotatate after the fact. Sometimes you don't need to go back in and try to get everything. You say, all right, well, this is where we're at, and you just watch closely.
So for a lot of patients with stage 4, widely metastatic neuroendocrine tumor, like they are symptomatic or it's heavy tumor burden, usually our general approach would be we start patient on a somatostatin analog, right? And then we probably just do restaging scan every few months and then wait until the cancer progress. However, we do have the NETA-2 trial showing that in patients with advanced higher grade, like case 7 greater than 10% or grade 3 neuroendocrine tumor, they found out that first-line PRRT improved progression-free survival compared to high-dose octreotide. So we do have those data. In your clinical practice, what is your approach? How do you usually treat patients with, say, these newly diagnosed metastatic higher grade 2 or grade 3 advanced neuroendocrine tumor? Do you do upfront PRRT for everybody because of the NETA-2 data?
That's a great question. So a few things to consider. The NETA-2 enrolled a higher grade population than the NETA-1. So the Ki-67 was 10 to 55%, but usually in the first line setting. And, it did show progression-free survival benefit, although we don't have overall survival benefit yet. So we'll have to see what that shows. And a few things to consider about PRRT is it's one of these treatments that you can use only a limited number of times in the patient's treatment journey. And so, we have a few great systemic therapy options and we also have local regional therapy options, but we don't have an infinite number of treatment options. So we have to consider that where it fits in the patient's journey. Our center is a little bit different in that we specialize in surgical debulking. And therefore, that usually gets sequenced earlier on in the patient's treatment journey. And so we tend not to use PRRT in the first line setting. I would say probably in my patient population, the patients I would consider is, let's say they have such a high burden of disease that they're going to get in trouble if they don't get some kind of response and they're not a surgical candidate. That probably would be the population I would consider for upfront PRRT.
Is there a Ki-67 threshold that, say, if it's above this number, that will push you more towards, hey, I probably need to do upfront PRRT rather than give them a shot and wait in 2 or 3 months or something?
Yeah, I usually consider it for the patients who are in that range, 10 to 55% range. If it's like 1%, I probably wouldn't consider it.
How about you, Rob? Do you do upfront PRRT for these higher grade patients?
So it's rare that we'll do upfront PRRT. I think with this disease, we don't have tons of data on the grade 3 patients. In fact, we've got data for PRRT and we've got data for cabozantinib and high dose SSA, I guess now. In reality, sometimes, a grade 3, they're very heterogeneous. So, you may have a grade 3 with a Ki-67 of 22%, but it sort of behaves maybe less like a grade 2, for instance. I was excited with the NETTER-2 data when it came out, a little disappointed that, again, we don't have that overall survival data. And keep in mind, if you treat enough of these patients, you're going to see that MDS and AML, these drugs are not without toxicity. So if we can get away with maybe a less toxic agent by the patient time, I'm usually starting with an SSA on most of these patients. Now the people I would think about for upfront PRRT would be those patients who are G3s, who have a high burden of disease, who are non-functional, and who, like Andy says, who are going to get into trouble if you don't do something. Because the response rates, they were much higher, in NETTER-2 than with PRRT than with an SSA. We know, we don't really expect a response. But, I would tend to save PRRT for afterwards. And especially if we're thinking about surgery, we definitely want to do whatever surgery we want to do prior to our PRRT.
Right. I agree. Interesting. You just mentioned about the high dose SSA data. So yeah, we usually start people with the SSA, right? And then after they progress on the SSA, usually like my traditional approach would be like we move on to get something else like PRRT or everolimus or cabozantinib or chemo, whatever. But we also have data on high-dose SSA, like the phase 2 single-arm Clarinet Forte trial showed that patients who progress on lanreotide 120 milligram every 4 weeks, they increase the frequency and give lanreotide every 14 days, actually resulting in a median progression-free survival for approximately 8 months or so, like for both GI and pancreatic primary. Is this something that you frequently do or rarely do, like increasing the frequency of SSA when they progress on SSA?
I have done it actually based on that particular trial data. In a minority of my patients, usually in the case of like mild progression, that I feel like I don't want to use up the PRRT just yet.
Right.
So,
like, what has your experience been?
We generally is similar to what the trial data show. It controls the disease for several more months, and then whenever then they progress, then they move on to PRRT or the next line of therapy. But getting insurance coverage can be tricky.
Right, exactly.
Right. Yeah, I guess I'm a little bit different. I think I've done it a handful of times, and the people I've done it with have no other options. So I want to go through all of my proven options. Keep in mind, this is a phase 2 trial. So I want to go through all my phase 3 data. So my PRRT, my everolimus, my cabozantinib, my sunitinib if they're pancreas, and or Captem for the right patient. So I want to go through all of that. And if the patient, for whatever reason, gets through all of that or can't tolerate all of that, sometimes we see people with renal dysfunction or severe cytopenias, and I can't give them these other agents, then I'll consider the SSA every 2 weeks. That's no walk in the park either for patients coming to get a treatment every 2 weeks. But yeah, I've used it a few times, but it's not something that I frequently go to.
So in your patient population, it will be very refractory patient who eventually get to like increased frequency. What has your experience been regarding the efficacy? Does it even work?
I think you can buy people some time with it, but yeah, it's not changing too much overall.
Right. That's how I feel. Like for a lot of different reasons, like patients very, very symptomatic when they're progressing a tiny little bit, or it's like an 86-year-old with tons of comorbidities, absolutely do not want to get anything else, including PRRT. Then a lot of time I would do it. I would say it's not a home run. Sometimes they may slow down the growth by a little bit, but sometimes like if insurance allows it, then it's a relatively easy treatment to give compared to like IV chemo, those kind of thing, or like some oral targeted treatment. So I do it, but I wouldn't say it's a home run or anything. And regarding like after patient progress on SSA, like you said, Rob, like we usually just move on to like other treatments. We have many treatment options right now. We have our target therapy, we have everolimus, we have cabozantinib. We still have sunitinib as a pancreatic primary. We also have like PRRT, cytotoxic chemotherapy such as CAPTAM or like FOLFOX for GI primary. One is the biggest question that I think anybody knows the right answer is how to sequence these treatments. In your practice, do you have general rules when it comes to sequencing? Say, do you have like, PRRT is actually always my go-to, or like cabozantinib or everolimus is my next go-to, or chemo is my next go-to?
Yeah, that's a great question. The prospective trials that are evaluating treatment sequencing, most of them are still accruing, so we don't have a lot of the data yet. Generally, we look at a few things, the pattern progression. We do a lot of liver-directed therapy for liver-limited progression. Sometimes we use that first before moving on to systemic. And, we also consider kind of the goal of the treatment. So let's say if you have a pancreatic neuroendocrine tumor patient with high burden disease or rapidly progressing disease that you need quick shrinkage, then we may use CAPTAM over PRRT because the responses happen faster.
I agree. It's there's a lot of papers that have been written about sequencing, and unlike some of our other malignancies where you start with this chemo and that stops working, you go to the next one, and then you can go to the next one, just follow the line. This disease is much different, and there's so many different things that we can do. So no one really knows the right pattern. I think generally we tend to think, starting with an SSA, upon progression, think about, depending on the type of progression, you think about local therapy, surgery, or liver-directed therapy. See how long you'd keep that patient on the SSA before you need to move on to something else systemic. When you do, people tend to think, all right, PRRT is probably the next best step, but it's sort of, it's not a one size fits all. I just saw a patient or heard about a patient one of my partners is questioning me about, and I looked at their scan and they have big, bulky mesenteric disease in an ocular met. So maybe this is not the person that I want to go to PRRT. Maybe I want to do something else, like everolimus or cabozantinib on this patient. It's really being able to know this disease and look at the patients and look at the scans and have your team approach and come up with the right treatment for that patient, knowing that, there may be more than one right answer. And that's what struggles, we go to these meetings and, around the country and talk to other experts, and sometimes we all have different answers.
Yeah.
Yeah.
I definitely agree.
Patients can get multiple opinions and they're all different.
Exactly.
And they're all right.
Exactly. I just you can't mix it up. That's sometimes I feel it that way. For me personally, it also comes down to how old the patient is, right? The comorbidities and the life expectancy ahead of them, right? If it's a very young patient, I personally would try to do anything that could potentially cause leukemia maybe a little bit later. That may not be my first go-to if I think about the risk of AML, MDS. Whereas if patient is actively working, I sometimes will be if say the small bowel primary, FOLFOX and FOLFIRI may be harder for them because they're still working. So I would maybe do something oral or, PRRT or something that they don't need to carry a pump for 2 days every 2 weeks. So for me, I definitely also consider the lifestyle, whether they're working and their age and everything as well. So definitely agree. It's definitely very personally tailored. But I do feel that other than SSAs lanreotide, long-acting ultra-tide, these are very easy to tolerate. Beyond that, I think the next easiest to tolerate is probably PRRT, right? And we talk about if we go to PRRT, a lot of times it's category 1 recommendation when people progress. Is there certain criteria when you look at the patient that you feel that, hey, this actually would be a perfect candidate for PRRT? When I see the patient, hey, I think we need to do PRRT right now.
I think if they have systemic disease that's somatostatin receptor expressing, generally they would be good candidates. Some situations that may make me think of other options, like Rob was saying, bulky mesenteric disease, sometimes we get bowel obstructions after PRRT and it gets tricky to manage after that.
I agree. I think, sometimes when I open up a dotatate PET and I look at the MIP and, you just know when you look at that MIP image, if it, lights up, you say, all right, well, this is getting PRRT at some point. And whether or not it has to be right now or later on down the line. it really comes into that multidisciplinary approach. And we meet every week we have a NET tumor board. And so we're very busy, and we're have our nuke med docs and our IR and surgery and GI, and and it's nice to be able to get the input of everybody. And other people may say, no, I can ablate that lesion. We're doing histotripsy now, and maybe that patient is not interested in having a needle put in them. And there's a lot of different things we can do before we even get to PRRT. And then we haven't talked about trials yet, but there's a lot of different things that are on the horizon.
Right, exactly. I personally feel that sometimes that will make me feel, I may want to save PRRT for a little bit later, would be if patients have very, very small disease burden, say if it's just a few periodic lymph nodes that grew a tiny little bit. I'm like, because I personally feel that PRRT is almost like, if not once in a lifetime thing, but almost once in a lifetime thing, right? So I feel like I may want to save it when I have like a bigger target for me to shoot. I don't know if you all feel the same way, or like regardless of the tumor burden.
Yeah. So, I mean, those people who, you're on an SSA and you have a new dotatate avid mesenteric lymph node. All right. So technically that person would have met the criteria to fit into NETR1, but do you really want to do that? There's easier ways to do this. I think the jury's still out as far as how many doses you can give. Generally in the US, we'll do 4 doses. There's a NET retreat study that is open and enrolling that's looking at 2 additional doses versus everolimus or cabo. So we'll get an answer in a prospective fashion. If you go to Europe, they'll keep going. We'll do it off-label as well. Depending on where you're at in the country, maybe it'll be harder, with insurers approving it. But we generally are able to get repeat PRRT in that by patients. So those patients who had their first round of PRRT and get a great response and a long duration of response, I have no problem trying to get it again, as long as their bone marrow and their kidney function allows it.
Do you have a feeling that like certain metastatic sites may not respond very well to PRRT? Say if it's bone lesions, peritoneum lesion, or I don't know, liver, whatever. Like, do you feel that there's certain part you were like, I experienced in the past that it did not respond very well, or you feel like it doesn't matter, every site respond if they respond?
I think it targets everything. I don't know if there's, any...
In my experience, I haven't picked up a consistent pattern, but I have definitely seen, within a single patient, their tumors responding differently, like their liver versus bone tumors.
And the bigger tumors, they tend to respond less. So we actually have a trial open at Vanderbilt that's looking at the role of surgical debulking prior to PRRT. And so what we're doing is taking all the patients, debulking every tumor over 3 centimeters, and then sending them to PRRT. So that's still enrolling. It's a pilot study. So I think we've got
we actually retrospectively showed that too, that the tumor volume matters.
Yeah.
Mm-hmm.
How long do you wait after surgery before you do PRRT?
In our studies, we are to start within 60 days.
Oh, I see. Within 2 months and then start. The reason I brought up the question is because I personally do a restaging scan after every 2 cycles of PRRT, because I do have patients who just like blow through PRRT. I have a few cases that the patient, like all the other disease sites are doing well, but during that interim restaging scan on the PET scan, there are new bone lesions. So I don't know if you ever had this experience. Like when that happened, what do you usually do? You finish the rest of PRRT, add like a Zometa or something bone modifying agent, or you have to switch treatment?
I think if the disease is responding, the patient is feeling better, and you happen to pick up a few bone meds, I think, I would keep going.
Yeah, I would too.
Yeah, I mean, if there's clear progression or the patient is going downhill and not tolerating, well, then maybe you've got to switch.
Yeah. And sometimes it's an artifact of the baseline scan you use for comparison. Sometimes you get a scan like 3 months before they actually start PRRT as the baseline.
Right, that's a good point.
So it may not necessarily progression.
Yeah. And then I think we just talked about like if patients have like very bulky peritoneal disease, PRRT would not be the greatest idea. I think it would be because we worry about small bowel obstruction, like what if they flare up and everything. Have you had patients who develop small bowel obstruction from the PRRT?
Yeah, unfortunately so, and it generally doesn't go well. We tried to prophylax with steroids. I think the Moffitt group published a paper of their experience of giving prophylactic steroids. So sometimes we do that if they have very bulky disease. But honestly, I don't know how well it actually works. Often if they get a bowel obstruction, it becomes very difficult to manage.
What is your go-to steroid regimen?
I give them like dexamethasone for 7 days, prior to the treatment, and then continue on for 7 days. So something I just like made up, adopted from the Moffitt paper.
So we do something similar. We start the day prior to treatment, 4 milligrams twice a day for 7 days. And so we said, all right, is this doing anything? So we actually went back and looked at our data, and we didn't have anything to compare to other than historical data. So we looked at ours, and it turns out that the rate of obstruction and tumor flare was not different when compared to historical data. Now, it's really going to take a prospective trial, multi-institutions, to figure out if this is really beneficial. But we do it thinking, all right, does this really help? But I can tell you, it's a real big problem. I just had a colleague today call me about this exact thing. The patient had a mesenteric mass, was deemed unresectable, went through an SSA, and now on PRRT, and developed a bowel obstruction, is now in the hospital after, I believe, 1 dose. So it's really, it's a problem, and it's something that we definitely need to be mindful of. And, PRT, as great as it is, may not be the best thing for everybody.
That's where the multi-D team comes in. So oftentimes we will consider surgically resecting the primary tumor if it's resectable, even in the setting of widespread metastatic disease, just to prevent these kind of complications.
Right. I personally, fortunately, have not. For patients with like bulky disease, peritoneal disease, I definitely do the same prophylactic, like the dexamethasone that Andy was talking about. Fortunately, my patient have not developed, but I definitely have a patient with very bulky peritoneal disease, like 2 huge cantaloupes sitting in the pelvis. They were like, okay, at some point in the future, I need to offer the patient PRT. Then we actually eventually do the surgery purely to prepare for maybe at some point in the future that we offer the patient PRT. But I also have patients with underwent a small bowel resection, and then after that, I think within a month, received PRT, and then actually developed small bowel obstruction, not from peritoneal disease, but from incisional hernia from his prior surgery. So that's why I'm very curious about the surgery and everything on your trial at Vanderbilt, and I'm really curious to see after enrollment and everything, how well these patients do and everything. That would be some interesting data to look at. Mm-hmm. And how about the other side effect that we talk about when we think about PRT would be, Rob just talked about AML and MDS, the leukemia risk. What has your experience with that? Is it something that you find it very common? Especially if you give people both temozolomide and PRT, do you feel that it's as high as the 8% risk of getting AML, MDS from the Moffitt data, or you feel that it's actually much lower than that?
I definitely have seen in my patients, which then makes you really consider, when to use PRT, especially in the young patients.
Yeah, you treat enough of these patients, you'll definitely see it. And it's really terrible to see because it's, there's not much, at that point you can do. The heme people, they tell me there's things they can do for treatment-related MDS now, but I think it's a really terrible side effect to get. So with the temozolomide, I think, we think about it, but I think we just don't know. Yeah, we definitely try to limit the temozolomide usage as much as we can, but, that doesn't mean everybody's going to get, MDS or AML if you get that combination. So we were just careful with what we do.
Right. And then we still don't know, my problem is we cannot predict which patient will eventually develop that, right? I don't think we ever find out a baseline, some abnormalities predict their increased risk of getting MDS from PRRT, right? I think that is my problem. I don't know who's going to develop PRRT related MDS, so I cannot avoid it, right? How about other systemic treatment option like oral target therapy and chemotherapy? We have CAPE-10, a lot of times we use FOLFOX FOLFIRI based on different primary sites, say pancreatic primary, lung primary, GI primary. Do you have a preference? Do you give them different treatment based on the primary? Would the response be different based on the primary?
Yeah, we use CAPE-10 quite a bit for pancreatic neuroendocrine tumors because it can really cause shrinkage, and it generally is pretty well tolerated. And so we use it quite a bit. And also for well-differentiated grade 3, we would consider it too, but generally not for like a low-grade GI neuroendocrine tumor. And we tend to sequence cabozantinib everolimus after PRRT, or that's just our practice.
Yeah, I think the CAPTIM story is interesting. I think traditionally we think about pancreas tumors, but we published several years back on our experience actually in New Orleans using CAPTIM in various types of neuroendocrine tumors. And the journal made us split it out between pancreas and extrapancreatic. But within that extrapancreatic cohort, we had lung and small bowel. And so there were responses there.
Even in small bowel?
Mm-hmm. Yeah, so albeit not as good as pancreas, but you can get a disease-free interval, with this. So it's an active agent. It's just, it's not one of these things that we go to regularly. So the CAPTIM, I don't, it's not one of my go-tos for small bowel, but certainly somebody with a lung tumor or a thymic tumor, I'll move to CAPTIM, especially if they have bulky disease, especially in lung. Our prospective data is really, really limited. We've got everolimus and cabozantinib. That's it. So all this other SSA and PRRT is all extrapolating from other things. Now there's the Alliance trial is looking at this in a prospective fashion, but that study has been hard to accrue to because PRRT is on guidelines. So it's hopefully we'll get some data out of that. But other agents, I guess the newest one is cabozantinib, and we're trying to figure out where that plays a role. That is, what's great about the Cabinet trial is they included the G3s, whereas the other studies didn't include those. So that's really their niche. And the data is good. So it's sometimes not the easiest drug to get through, but I think it certainly has a role.
Yeah. So that's actually my next question for you, because I know like Rob is the lung neuroendocrine tumor specialist expert. So for typical or atypical lung carcinoma, like I think half of them, the tumor is not even avid on dotatate PET, which will make like somatostatin analog or PRRT not even a legit option for them. So what are your usually favorite treatment? Would it be like the ones that you just talk about, like CAPTIM, everolimus, cabozantinib?
Yeah, so the lungs, if they're not dotatate avid, then you have two treatment options that you take out for the menu. So now you're left with cabozantinib or everolimus, which are those that have actual prospective data behind them. Things like CAPTIM we could consider as well. There could be a role for some chemotherapy. This is where I'm sending NGS on patients as well and seeing, there's case reports of EGFR mutations or ALK rearrangements in these. You don't see them, but unless you look for them, you won't know. Most of the time, you don't find anything. We do a lot of local therapy as well. So liver-directed therapy, we'll do SBRT for lung tumors. So there's several different things that we can do even though we don't have, the greatest data set. And I think that's one of the big strengths of Cabinet is actually included lungs rather than after the fact going back and saying, all right, so let's do this afterwards. So, more to come.
I feel like many of our lung patients, their tumors are heterogeneous. Like the liver tumors don't light up on dotatate, but their bone and lung tumors light up. Do you ever consider PRRT for those patients and then use local regional therapy to treat the liver?
Sure. In that exact situation, if I can clear the liver of their non-avid disease with whatever local therapy, and then could certainly consider an SSA or PRRT.
Right. To echo Andy's point, I definitely have patient, I feel the same way, right? Like one part of the lung neuroendocrine tumor is not avid, but the other part is avid. And sometimes I also give people the somatostatin analog a try. I'm like, it doesn't hurt anything. Why don't we just give it a try? I definitely feel the same way. How about, the reason I ask this question is because there's other oncologist asked me, for well-differentiated low-grade neuroendocrine tumor, low grade, not high-grade grade 3. Do you use immunotherapy?
I think the data is slim to none with that population. In the lung, interestingly enough, there is some data for dual immunotherapy. And if I get to a point where I'm running out of options where I don't have anything else, I'll reach for it. And I've seen some pretty dramatic responses. In fact, I just heard about a patient that I treated in New Orleans recently who's been on Ipi-Nivo for a number of years and doing great. She had big bulky disease and it all went away.
Is it more like atypical, like a high grade, more aggressive, or it's very indolent?
I don't recall her if she was typical or atypical at the time, but I think there's, again, it's not something we reach for all the time. And we all get patients who ask about this. They've heard of the drugs on TB and what about this? And my friend was on this. And you just need to say, look, we don't just tell, it works great for those diseases, but in this disease, we just don't have good data to support it.
I would say in GI, one of the phenomena we've seen, I think especially in pancreatic neuroendocrine tumors, is after CAPE-10 or after PRRT, the tumor kind of evolves and then different clones emerge. And then sometimes you rebiopsy, and I think related to the temozolomide, you can see this like hypermutated tumors, and some of those patients respond very well to immunotherapy.
Interesting. That reminds me, I probably after many years of treatment, I probably need to rebiopsy them again and just do the NGS and everything. Okay, so very last part is a different part. It's not on neuroendocrine tumor, it's on neuroendocrine carcinoma, but this is so important for me. That's why I'm I have all the experts here. I'm going to ask the question that I really want to ask. So for extrapulmonary, so not lung small cell, but extrapulmonary poorly differentiated neuroendocrine carcinoma, what do you usually use for first-line treatment? And do you add immunotherapy to first line?
I personally don't, but I tend to enroll them in the SWOG study. So that's carboy toposide plus minus atezolizumab with different dosing regimens of the atezolizumab. So I usually send my patients to get on that study for first line. But most community oncologists do.
Right. That's what I see. But GI, a lot of times, just because GI primary, a lot of times don't respond to immunotherapy very well. So I always question, that's why I want to see that trial data to see if we truly need to add immunotherapy frontline. How about you, Rob?
Yeah, I'm the same way. Platinum etoposide first line, I try to get them on the SWOG trial. If they come to me and they're already on immunotherapy, I don't tell them to stop it, I just tell them we don't have the data that this is beneficial. Where it gets a little tricky is sometimes in the adjuvant setting as well. So I just actually had a patient several months ago who had an EP neck and had definitive chemoradiation, and then came to me for an opinion regarding immunotherapy.
So small cell lung cancer?
Correct. And I said, we don't have the data. So with that disease, there's a lot of extrapolation from small cell, and we know it's not small cell lung cancer. So we can't really do that.
How do you feel about lurbinectedin and atezo maintenance? I see community oncologists do that all the time for EP necks.
I've never done that. So
I never done that either.
Yeah. For small cell, the data is there, and even with that in the lung world and with that trial, we're sort of on the fence as far as those Werby's not the easiest drug to get through, and so these people are usually beat up already. So in the extrapulmonary neck, no. What I'm excited about is obrixtamig. So that that trial is opening soon. That's going to be frontline platinum etoposide with obrixtamig, which is a bispecific T-cell engager against DLL3. So the early data, the earlier studies, they look really, really good. So we're excited about that. In some cases, I'll do DLL3 testing in my necks, and if they are high expressors, then we can make an argument for tarlatamab.
Yeah, surprisingly, we've been able to get it covered.
Yeah, I actually check all my neuroendocrine carcinoma, small cell, large cell for DLL3, but sometimes I get a 1%. So, and then that's my question.
Right.
When is it quote unquote positive that I should try to use tarlatamab?
Well, probably not in a 1%, but if you have a high expressor and someone who fits into that neuroendocrine carcinoma category, I actually just had a patient.
I feel like it's either low or high. It's never in between.
Yeah. I had a patient, and this happens all the time, where patients with typical carcinoid, it'll get read out as a neuroendocrine carcinoma and the patient gets treated with platinum and etoposide and doesn't respond. And so they go get another opinion and we say, oh, actually, you don't have a neuroendocrine carcinoma, you have a typical carcinoid tumor or an atypical carcinoid tumor. So that happens a lot, actually. But recently, I just saw a patient with typical carcinoid that was treated like that, but in the meantime, they had sent off DLL3 testing that came back at 100% positive of typical carcinoid. So maybe there's a story there. I don't know.
Interesting. So maybe we should be testing all our typical and atypical
I don't know, maybe.
Right? That will be interesting to see. And how about your experience with ipi-nivo? Like we know that we have data on ipi-1 nivo 3, actually different way that we give it, but do you usually give it to your patients like second line, third line, whatever line to treat neuroendocrine carcinoma?
I've done it, but not just because I were out of options. For EP next, I haven't seen that great results, at least in my patients.
Yeah, I agree. I think after platinum and etoposide, if I don't have a trial, I'm usually reaching for FOLFIRI.
Mm-hmm. Yeah, I do use ipi-nivo for a lot of my neuroendocrine carcinoma patient. I did have one that was a home run. Like it's a gallbladder small cell humongous pain because of bulky disease. After I think 1 dose of treatment and the pain is gone. So the tumor just shrunk by 70%. However, it developed severe side effect. So we had to stop it, and that's how I feel. It's like if it works, then I will continue with it, and then at some point I'm gonna have the side effects and everything. We still don't have a perfect solution for this patient, but I'm glad that a lot of things are on the horizon. Just for neuroendocrine neoplasm in general, can you tell us what has been on the horizon that like specific trials, certain PRRT treatment, therapeutics that make you like very excited about?
Yeah, one of the big excitements in the field is alpha particle PRRT. So there are several trials that are ongoing. So it remains to be seen, after more mature data, how these will hold up against the conventional, like Lutathera. Yeah,
I agree. I think we've got several trials open. So there's the VMT led 212 that we've got open, and we've got patients on that. They're doing great on the early data. It gets presented at every
every meeting.
It's updated at every meeting, and so we'll see data at we just saw some data at AACR, and there'll be data at ASCO, and it all looks good. And what's interesting is we had data on the other lead 212 compound from AlphaMedix, which also looked good as far as treatment efficacy. The problem with it was pretty toxic, especially with a significant amount of dysphagia and a good amount of renal dysfunction. So, we'll figure out what happens with that compound. The other thing that we're looking forward to is the actinium-225, the Action 1 study. That study's close to enrollment, so we'll see, when that data comes out, hopefully later this year, early next year, just where things are at there. Raise Bio is opening another study. It's using a Raise 401 compound that is also actinium-225, except their compound does not require the use of amino acid. So it cuts down on chair time by about 3.5 hours. So that's a phase 1 study. We have our SIV coming up in a few weeks. And so there's a lot of these things that are happening, outside of theranostics. There's the zanzalintinib that is a multi-kinase inhibitor. So, we'll see how that holds up. That's being tested against everolimus. So there's a lot of these.
There's a CAR-T study now,
right?
CHM-2101 against, I think CDH17, but we have it open. It's a phase 1, so we'll see how it goes. But there's a lot of excitement in the neuroendocrine community.
Yes, Absolutely. So for like these patients, say they're on the VNT trial and in the future they progress, but they never got, say, Lutathera before, would you consider treating them with Lutathera again?
I don't think so. I mean, I think in my mind anyway, it would sort of be akin to someone in the lung cancer world getting osimertinib and then progressing on that and then going back and getting erlotinib. So this is like the next generation of things. But we could think about treating them again.
Right.
After they progress.
If it's been, like 18 months,
Yeah. That, of course, a lot of very exciting things happening in the field. And like, think about our portfolio compared to, say, 15 years ago. It's completely different right now, right? So hopefully in the next 10, 15 years, we have more exciting things for it to come and further prolong our patients' survival. Okay. And with that concludes today's episode on systemic treatment for neuroendocrine tumor. Thank you so much, Andy and Rob, for joining us. I learned so much from your experts, and hopefully we'll meet again soon. But thank you so much for your time, and thanks for joining us today.
Awesome. Thanks for having me.
Thank you.
Yes, thanks for having us.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableOnc. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, and LinkedIn. BackTable is produced and hosted by myself, Kate Baker.
Our production team is led by Kieran Gannon,
Aaron Bowles,
John Reyes,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
music by Aaron Bowles.
Thanks again, and see you next time.